Today we're going to talk about the inferior alveolar nerve block, or the IANB. Mastering this technique is the ultimate goal in local anesthesia, because if you master this injection, all the rest are not a problem at all. So today I want to start by discussing this injection technique, give you some tips, best practices, and that can really help you feel more confident in giving this injection. So it's important to know that the anatomical landmarks that exist in this, you have to know, first of all, where the coronary notch is located, and it's really essential. What I'm going to do is I'm going to show my mandible here, and I'm just going to give you some insight to where this is. Now, here, you see the deepest part of the ramus, or the mandible. The deepest part is the coronary notch. So when you see, a practitioner going up and down with their thumb or finger all along here, they're searching for this notch. The patient has to be open pretty wide to get this, but that is the coronary notch, the deepest part of the ramus. If you look at my hand, and I'm going to hold my hand up next time too, and you see if I put my finger here, okay, you see the deepest part of my finger and thumb? That would be where the coronary notch is. So that's another good explanation of this. You can see that deepest part. Be sure the patient opens really wide so you can see this and pull the tissue taut against the coronary notch. So that's the first one, the coronary notch. Secondly, you need to find another anatomical landmark, the Pterygomandibular Raphe. Now again, knowing exactly where this is located is crucial. The cool thing is that it'll perfectly line up with the coronary notch. So when the patient opens really wide, take your cotton tip applicator and draw a horizontal line from the notch to the deepest part of the Raphe. It'll make a perfect horizontal line. So if I take my cotton tip applicator, and I know that we don't have a pterygomandibular Raphe here, but you see at the deepest part, the notch is deepest part will line up perfectly also. So sort of again, I'll take my hands, sort of, and you can see that if that perfectly lines up, horizontal line, the deepest part. So that will be helpful. So to get that perfect horizontal line. So now the third anatomical landmark is the height of injection, where that horizontal line is. And it's usually about 6 to 10 millimeters above the occlusal plane. So from there, you need to figure out where along that horizontal line will the needle need to go. Okay, the easy part was finding the horizontal line. Now, where along that line do I go? Okay, if I take my cotton tip applicator and move it about 3/4 away from the coronary notch and about 1/4 away from the pterygomandibular Raphe, the cotton tip's going to drop right into the pterygomandibular fossa. Now, there's a good visual of that, and I want you to take a look at that. And note that that fossa, though, goes all along the Raphe. That's why it's crucial to know that horizontal line. So you already did that. So guess what? You're now at the site of injection. Good job. Since you found that site, now you'll use your 25 or 27 long needle, and you got a 25 and a 27. Okay, 25 is red and 27 is yellow. These are very rigid. This is the most rigid, and this is about medium rigid. And then, of course, there's 30 needles too, gauge needles. I don't want you to use a 30 short ever. It's always a long needle, 25 or 27, so either one. And whichever drug of choice for the anesthetic. Be sure that the harpoon is engaged to the rubber stopper of the cartridge and that the bevel of the needle is always pointing toward bone. Okay, so the syringe is held so that the large window always faces you for dispensing, speed accuracy, and you'll want to ensure 2 negative aspirations. So if you're wondering, well, I don't get what this bevel is, what are you talking about? So high-speed suction tip, right? Well, isn't that a nice looking bevel right there? Okay, so the bevel always is pointed toward bone. So I'm going to hold up my jaw again. And if you could see, if I'm going to do the right side and I'm a right-handed operator, the bevel has to face me. Okay, the bevel, because the bevel's facing bone. If it isn't, and the bevel's facing out, we're going to be putting local anesthetic toward the tongue. We don't want to do that. We want it facing toward bone. Okay, so bevel toward bone always. So you want to always advance, starting with the barrel of the syringe at the second premolar on the contralateral side. Well, what do I mean by that? Angulation is really, really important. So I'm going to hold this up, and I'm going to come from the second premolar on the contralateral side. Okay? Because if we don't, and we go to the same side, how are we ever going to hit bone? We're going to keep going backwards. We don't want to do that. Okay? You've got to be contralaterally so that you can hit the bone. And remember, the bone is to be hit right here Okay, this is called the lingula. And right behind the lingula is the inferior alveolar nerve foramen. And that's where we want to hit because we want all that solution to just diffuse into that foramen. Once we're all set with our syringe, everything's ready to go. We have our bevel toward bone. We're going to advance the needle until bone is hit at about 20 to 25 millimeters or 3/4 of the needles embedded in tissue. Once you hit the bone, back up from the bone about a millimeter and aspirate 2 times. If negative, deliver 3/4 of a cartridge of anesthetic, saving 1/4 of that cartridge for another injection called the long buccal. So when we are using our aspiration idea, a lot of people get confused about that. So remember, aspiration is just pulling back on the thumb ring, right? We're pulling back on the thumb ring. We do one aspiration, looking at our barrel to see if there's any blood coming in here. And then I kind of turn, have a 45-degree angle, and then aspirate again and see if it's any blood coming into the needle. I always do 2 negative aspirations before I give my injections on all my injections, just to make sure, because you don't want to be in a vessel. If you are, the target sites are the brain and the heart, and if that would not be very comfortable for your patient, and there's possible concerns of overdose. Now that we've done that on the perfect anatomy patient, is every patient at that perfect anatomy? Of course not. So again, it's important to problem solve. And here are a couple more tips. So let's say you started advancing the needle, but it hits bone way too soon. This means you've hit the bone too anteriorly. Well, what do I mean by that? So I'm going to hold up my mandible again for you guys. And if you see, we're going in and we hit too anteriorly, meaning when I go into the tissue, I only go in about a half a needle length or 1/4 of a needle length. Remember, you have to be 3/4 of this needle has to be embedded in tissue. So what do we do? Well, because we've hit too anteriorly, we withdraw the needle slightly and move the syringe barrel more anteriorly. So what do I mean by that? Okay, I've hit too soon. Okay, so I'm going to move this more anteriorly, the barrel. Okay, and when I move it more anteriorly, the needle goes more posteriorly. So advance the needle until you reach bone within 3/4 of the needle embedded in tissue. So try it again. So second scenario you might encounter, you start advancing toward bone, but you're not hitting anything. You're not hitting bone at all. Note, you should never advance the needle into tissue to the level of the syringe or needle hub. Okay, so what that means is, if you see right here, this is a needle hub right here. I don't want to advance the needle all the way over to here. Okay, that is the weakest part of the needle, and you could break the needle, so we never do that. Okay, you must always see about 1/4 of the needle to prevent any breakage. So if you don't hit bone, you are too far posterior with your needle now. Okay, meaning, I'm going to do this again. If we go in and we're not hitting anything, okay, we're going in and we're going, oh boy, nowhere. Okay, that is concerning. Okay, it's because you could be too far back and close to the parotid gland. And that gland is surrounded by the facial nerve. So if you dispense, let's say you think you're in the right place, you didn't hit bone, but you think you're in the right place, you could risk anesthetizing this nerve, causing facial nerve paralysis. So to avoid any chance of this happening, you must hit bone. We always hit bone. On every injection IANB that we do, we have to hit bone. So we withdraw the needle slightly. Okay, and now I'm going to move the syringe barrel more posteriorly. So if I do that, look what happens. The needle moves more anteriorly. So what's called an anterior posterior position. When the barrel moves one way, the needle moves the opposite way. Okay? So this will put your needle more anteriorly. Advance until you reach bone with 3/4 of the needle embedded in tissue. Again, when you hit the bone, pull back a millimeter, never inject on bone, aspirate 2 times, be sure you're not in a vessel, and then if negative, deliver 3/4 of the cartridge in a little less than 1 minute. Okay, so it should take 1 whole minute for a full cartridge to be dispensed. We're doing 3/4 of a cartridge, that's a little less than a minute. So after successful administration, sit your patient up in a semi-supine position. This will let gravity take effect. Since you administered at the main branch of the inferior alveolar nerve, about right here, you will need that anesthesia to disperse to the entire nerve, which goes from here all the way along until the central incisor. So sitting them up in a semi-supine position will help disperse that. Now the patient's lip and tongue will feel numb. So you want to ask the patient, how does your lip feel? And how does your tongue feel? And if they say they're both feeling numb, that ensures you have sufficient anesthesia and that you've reached your target. Mastering this injection means you'll have an impressive skill set under your belt. In fact, did you know that the inferior alveolar nerve anesthetizes 4 areas? It's made up of the inferior alveolar nerve, from which the mental and incisive nerve branches off at its anterior portion. So that's 3 nerves for anesthesia. And from there, the lingual nerve, which lies anterior to the inferior alveolar nerve, is anesthetized through diffusion. So 4 in 1 injection. It's pretty cool, right? The most important key takeaway is not to make any guesses when it comes to this injection. It's really too critical and the anatomy is way too precise. With your knowledge and strategies that we've discussed today in this video, and of course, lots of practice, you will master this injection. Then all the rest of your administering local anesthesia will be a piece of cake. Thanks for watching. Hope you enjoyed this video and I hope it helped. Have confidence, you got this. Click on the link below to stock up on any of your must-have anesthesia supplies so be ready for your next inferior alveolar nerve block injection. Thanks.